Hello, and welcome to this episode of the Radiology Imaging Cancer Podcast. My name is Brandon Fields. I'm a trainee editorial board member and resident at the University of California, San Francisco. I'm here with Dr. Gary Luker, editor of Radiology Imaging Cancer, and Dr. Allison Applebaum, who is our honored speaker and guest. A little bit about Dr. Applebaum. She is an associate attending psychologist in the Department of Psychiatry and Behavioral Sciences at Memorial Sloan Kettering Cancer Center, as well as an associate professor at Weill Cornell Medicine. Dr. Applebaum received her PhD from Boston University and completed a residency at Weill Cornell Medical Center, New York Presbyterian Hospital. She completed her fellowship at Memorial Sloan Kettering Cancer Center and is the founder of the Caregivers Clinic. The Caregivers Clinic provides comprehensive psychosocial care to family members and friends of patients who experience significant distress and emotional burden as a result of their caregiving role. And in today's episode, we'll be discussing Dr. Applebaum's journey throughout her founding of the clinic and growing it into what it is today.
Fantastic. Thank you so much for having me.
So, Dr. Applebaum, thanks for being here. We'd love to hear a little bit more about the early days of the program. How did you get into founding the Caregivers Clinic? What challenges did you face, and what inspired you to really get into this field of work?
Sure. So I came to Sloan Kettering Cancer Center initially when I was a clinical psychology intern at Weill Cornell Medicine in 2009, and then joined formally as a postdoctoral fellow in 2010. And at that time, I was struck by what a phenomenal job the field of psycho-oncology was doing to support patients with cancer. This is a field that addresses the mental health of patients with cancer. There was phenomenal support available to patients at Sloan Kettering, as well as in cancer centers across the country. But I realized that we were really missing the mark in terms of what was available to the family members and the friends and everyone else who already back then was playing such an instrumental role in patient care. And I realized that these family caregivers, these parents, these partners, children, friends, siblings, colleagues, neighbors, were deserving of their own support. And so a year later in 2011, I founded the Caregivers Clinic, whose mission is to assure that no caregiver experiencing significant distress as a result of their caregiving role goes unidentified and deprived of necessary psychosocial services. So the clinic was founded in 2011. It's been a little bit over 10 years since its inception. And I'm excited that I'm able to speak about it here today.
That sounds really wonderful, and we're happy to discuss it as well. It seems like it's made such an amazing impact on the way in which we perceive holistic care, both for patients and for those who are supporting the patients along the way. What are the biggest ways you see this program impacting the ways in which we experience cancer care?
Whenever I get a question like this, I think back to something one of my first patients told me. And she said that what I am doing for my mother, this was a caregiver, what I am doing for my mother is just as important as her chemotherapy. Family caregivers play an instrumental role in the care of patients. We know that the availability of a supported and mentally healthy and caregiver who has the capacity to take on their responsibilities, in many cases, can mean the difference between life and death for patients, and in all cases can mean a difference in quality of life for patients. And so when we think about holistic care, I don't think that we can even provide holistic care without attending to the needs of family caregivers, because patient care never happens in a vacuum. When patients leave your medical office, they go home, often to a network of care of other individuals who are involved. And it's really important that we begin to attend to the needs of these family caregivers so that that care can be as comprehensive as possible and not lead to detriment on others in that family caregiving network.
So, how do you identify the caregivers? Are they referred to you directly, or do they find out from the oncologist? How do you identify the key people with whom to interact about this program?
Many different ways. So certainly caregivers self-refer themselves to us. They see information about the Caregivers Clinic posted on our website, on billboards, and on advertisements within the institution. But certainly an equally large number of caregivers come to us from our medical oncology colleagues who, for example, in meetings with patients and family members might notice that the caregiver in that room is distressed and may offer that caregiver information about the Caregivers Clinic. We also have phenomenal offerings through our Department of Social Work at Memorial Sloan Kettering Cancer Center for family caregivers. We have lots of support groups that meet monthly And oftentimes caregivers who attend these groups find that they want a little bit of greater support than they're getting just in those monthly groups, and then they come to us. And then finally, we have clinical trials for family caregivers at Memorial Sloan Kettering, where we are evaluating the efficacy of various psychotherapeutic approaches to address caregiver distress. And so oftentimes after completing these trials, caregivers may say, you know what, I need a little bit more help, and they'll reach out for support. So folks come to us from a variety of different sources.
Can you tell us a little bit more about the services that are offered at the Caregivers Clinic?
Absolutely. So we provide psychotherapy, psychosocial support delivered primarily individually to family members and friends of our patients. Caregivers come to us and they'll have an initial psychodiagnostic visit where we get a sense of how they're doing, not just emotionally, but in terms of all areas of psychosocial functioning and areas of unmet need. And then caregivers go on to receive most likely individual psychotherapy. And the sessions are really tailored to the unique needs of every caregiver. So we're not a typical psychotherapy clinic where folks come weekly for their therapy session. For some caregivers, coming in for just a handful of sessions is enough. For others, coming in for months or even years is necessary. And we really tailor the therapy to the needs presented. So for example, some caregivers come in and they share that they are here because they are really concerned about how to speak with their loved ones and the medical team about healthcare, about difficult conversations around advanced care planning, and feeling like they don't know how to initiate and open those conversations. And so for those caregivers, oftentimes just a handful of sessions that focus on communication skills is enough. There are other caregivers who come in and share they're experiencing moderate or severe psychopathology, severe depression, potentially even trauma symptoms, and they require a more intensive course of care. And we certainly have many caregivers who come to us and they share that they are experiencing what we call existential distress. And this is not a DSM-5 category. It is the distress that we all experience when we realize that we are human and we're mortal, and we and our loved ones will eventually all die. And caregivers are forced to reckon with existential distress, regardless of the site or stage of their loved one's cancer, regardless of the prognosis they've been given. And so many caregivers come in with concerns just around the future, around whether or not they're going to have a future with their loved one, around their own sense of identity now that caregiving has taken such a prominent role in their life. We always try to deliver care that is in line with empirically supported treatments. Those interventions we know work. And so we rely heavily on the cognitive behavioral therapies, for example, as well as some mindfulness-based approaches. And we also like to implement some of the psychotherapies that we've been developing at Memorial Sloan Kettering Cancer Center. So for example, over the past 15 years, because of that existential distress, some of my work has focused on developing an approach that's called meaning-centered psychotherapy for cancer caregivers, which gives caregivers the tools to experience the suffering that they experience as a caregiver. We never invalidate suffering, but we give them tools to help them to cultivate a sense of meaning and purpose in caregiving despite their challenges. And so we certainly try to deliver therapy that we know works and also therapy that's tailored to their unique needs. We have at MSK very wonderfully a separate couples and family therapy program. This is separate from the Caregivers Clinic, but certainly within the Caregivers Clinic, we do provide ad hoc couples and family therapy sessions, oftentimes 1 or 2 sessions between a caregiver and a patient, where we, for example, might address difficult conversations around advanced care planning or the emotional side of death and dying. These are opportunities for me to ask the patient or say to the patient, I've known your wife, let's pretend, I've known your wife for a collection of 4 hours, but you've known her your whole life. What is important for me to know as her provider to take care of her after you're gone? And that leads then to some of the most powerful sessions that we have in the clinic and that really allow us to provide very meaningful care in bereavement. So we do provide ad hoc sessions to couples and families. And on occasion, we also conduct group psychotherapy. But the primary modality is individual, and that's because caregivers are burdened. They have a million responsibilities, and trying to coordinate group sessions is often very difficult. So we try to provide the sessions at a time that is convenient for family caregivers.
Some of this sounds very emotionally challenging for you as a caregiver for the caregivers, if you will. How do you manage that aspect of your work?
Big existential question. I think one of the silver linings of psychotherapy training, going to do your doctorate in clinical psychology and all the steps that it takes in this particular profession, is that in order to be successful as a clinical psychologist, we all must develop the skills to compartmentalize. And so I am able to compartmentalize my professional and personal, my professional work from my personal time. It doesn't mean that I'm not affected emotionally, but it does mean that I am able to not be deeply negatively impacted by it. I should say, though, that while, yes, I and my colleagues bear witness to some very difficult moments, we are present with families at some very incredibly painful transitions. On most days that I see caregivers in my practice, I leave feeling inspired. I leave feeling uplifted because I get to hear about the incredible ways in which humans are making difficult choices, and humans are expressing love, and humans are redefining their goals. And so while, yes, it can be difficult at times, and if you catch me at the end of a clinic day, I probably won't want to talk for a little while, deep down, the benefits to me are actually quite great.
So, if you're able to share, and just dovetailing off of that, what are some of the largest challenges or stresses do you think that affect caregivers? And what are some strategies in which we're able to lend them to cope and overcome those challenges?
Gosh, there's so many. Well, first of all, cancer care is moving to the home. And I think it's important for us to state that even when I began this work in 2009, 2010, family caregivers were already being asked to shoulder tremendous responsibilities. But that has only increased exponentially since that time. And, caregivers are asked to perform medical and nursing tasks that were once those only performed by you all, the trained medical professionals. And oftentimes they're asked to do so with very minimal training and support. And this is a very, very key driver of distress, of emotional distress in family caregivers. Caregivers feel understandably like they have their loved ones' lives in their hands. And in many cases, they absolutely do. Another big category that drives distress is the fact that we do not, in this country, nationally, have a robust paid family medical leave plan. Certainly, there are state-by-state policies, but by and large, family caregivers are often asked to make a very difficult decision between paid employment and family caregiving. And for those who don't make that decision, trying to balance two full-time jobs, because cancer caregiving is a full-time job. On average, it's 8.3 hours a day for 13.7 months. So it's a very, very, very difficult balancing act, and that leads to distress. So those are some of the real logistic challenges that caregivers face. And then, of course, there are the other deeper existential challenges that caregivers face, which is regardless of the site or stage of one's cancer, regardless of what treatment has been laid out, every caregiver is faced with one common challenge, and that is the difficulty with sitting with uncertainty, with not knowing what the next year or month or week or even day, and in some cases the next hour may bring, and therefore not being able to plan their lives, plan for the future, and feeling like there's a lack of control over their lives. And this is something that very much shapes the experience of caregiving and drives distress.
I will just say parenthetically to your comment you just made that even as someone trained in medicine, providing care as a caregiver to a family member, which I've done recently, you still have those same feelings of I'm not really qualified to do this because it directly impacts a person you love.
100%. And that's something I talk about in the book that I have coming out, Dr. Luker, that even for those of us who are, you all are trained medical professionals. I, of course, have my real doctorate, but my honorary medical degree, which I got while taking care of my dad. But even with the medical training I've had and my experience in healthcare communication and navigating our hospital systems, I felt like I didn't have the skills necessary. So we can only imagine what it's like for so many individuals who don't have the training that we all have in healthcare to provide care to loved ones.
You did mention your book coming out. Can you tell us a little bit more about it?
Absolutely. So in February 2024, my book, Stand By Me, A Guide to Navigating Modern Meaningful Caregiving, is coming out, published by Simon Element. And this is a narrative nonfiction compilation of my dual experiences in developing and leading the Caregivers Clinic at Memorial Sloan Kettering Cancer Center, and then concurrently serving as the primary caregiver for my father, Stanley Applebaum. And in each chapter, I bring in lots of case examples from the Caregivers Clinic. And what I've tried to do is to distill some of the main points of intervention that we deliver in the Caregivers Clinic to help caregivers, for example, to learn how to sit with uncertainty, to navigate advanced care planning discussions, to, for example, have very difficult emotional conversations with family members who might not be helpful, to facilitating home care and addressing grief. And so this is one way in which I'm hoping to help so many of the 53 million American caregivers who don't have access to the type of support we have at Sloan Kettering, but who are desperately in need of some support. And of course, behind that, it's an opportunity for me to honor my dad and our relationship as partners in care.
The 53 million number you just stated is staggering to my perception in terms of how many informal family caregivers are called upon to take on essentially a new full-time job. You have started a remarkable program at Sloan Kettering, but what are ways to make that national priorities? Because it seems to be an important role that you're filling for many people.
I'm going to answer that, but forgive me. Before I do, I want to make an important point. And this is something I've been talking about recently. I think we need to, as a community, shift the language we use in describing family caregivers. You use the word informal caregiver, which full disclosure is a phrase that I used in a lot of my writing up until the point of my dad's passing in 2019. And I realized that in using the phrase informal caregiver, I was doing a disservice to all of us who serve as family caregivers, because there's nothing informal about the work that we do. So I just want to point that out and say we are family caregivers, we're partners in care, we are superhumans, we're superheroes of the team, but we're not informal.
I appreciate being corrected. Thank you.
I'll get off my pedestal here.
No. I appreciate learning.
So we are in a really exciting moment in this country. I actually returned just 2 or 3 weeks ago from Washington. I was with the National Alliance for Caregiving for their first in-person caregiving summit and Day on the Hill. And this was an opportunity to bring together 150 advocates for family caregiving across the country, not just cancer caregiving specifically, but to bring together advocates and talk about policy changes, and actually for us to have the opportunity to speak to some of our congressional representatives about some of the things that are happening. And very excitingly, about a year ago, the Department of Health and Human Services actually released a national strategy to support family caregivers, the first of its kind. And they created a blueprint to address the needs of that 53 million caregivers that you mentioned. And one of the primary goals of this blueprint is to actually strengthen the supports available for family caregivers in this country. And it's outlined 350 federal actions, many of which are aimed at helping to identify caregivers early, to identify what their needs are, and to develop supports so that caregivers can get the type of care that they need over time. So we're in a pivotal moment, and I hope that in 5 years from now we can say that these have been implemented. I'll also say that our current public policy landscape is reflecting some changes that I think are centering caregivers in care. And the first is, for example, what's called the CARE Act, the Caregiver Advise, Record, Enable Act. And this is currently passed in 45 states and territories, and it requires hospitals to do 3 things. It says when a patient is admitted, the caregiver's contact information must be documented in that patient record. Number 2, that caregiver must be notified when the patient's going to be transferred or discharged. And number 3, the hospital must provide training and education to that caregiver so that they know how to take care of their loved one when they get home. And right earlier, I said that one of the most primary driver of distress is all of the new medical and nursing responsibilities. But the CARE Act is actually saying no caregiver should go home without that knowledge in place. Now, is it implemented consistently? No. Should it be? Yes. Probably steps need to be taken to make it happen, but it's definitely a big step in the right direction. And I think that with this national strategy, not only will we see improvements in the types of supports available to caregivers in our hospitals and healthcare systems, but also things like tax credits for caregiving and other benefits that will eventually help caregivers to have a little bit more financial stability and security, and maybe even funds that can be used to support mental health care.
That's amazing. I did not know about that act, so I think that's quite remarkable in terms of the support that could be offered to people. I have noticed that, at least here at the University of Michigan, in intake questionnaires, that now there are questions focused toward caregivers. Are you having distress? Are you feeling anxious, concerned? And as I said, from my experiences, I certainly checked yes to all of those.
Every caregiver will check yes. Yes. Anxious, yes. Concerned, yes.
Well, it truly must be amazing to see how far the program has come since its inception. What directions do you view it going the next 5, 10 years, maybe even as it expands to other institutions on a statewide or even national level?
Yeah, so my hope at this point is to be able to take the model of care that we've developed in Memorial Sloan Kettering and disseminate it. And so, actually, towards that end, some colleagues and I are working to secure funding from the NIH through an R25, where we will provide training to cancer centers across the country to develop similar family caregiver support programs. We're also partnering with the American Cancer Society to develop a toolkit that we can disseminate to cancer centers that can provide high level guidance on how to develop these programs. The reality is that the establishment of this program didn't take more than one very enthusiastic fellow, myself. And so certainly there was a lot of buy-in I needed to get from the institution and steps that I took eventually, but ultimately having just one, what I'll call a family caregiver champion in a cancer center is enough to get started. And so really the way I see this, my hope is that in the next 5 years, 10 years, every comprehensive cancer center has a caregivers clinic. And then if we expand out from there, I think that obviously this is not an issue that's cancer specific. Every healthcare system should have support for family caregivers.
When we were talking in advance of this podcast, I remember you mentioned some clinical trials where you had been somewhat astounded at the design that essentially required a caregiver to be present full time for some astronomical number of weeks or months. So, do investigators engage you or your clinic in terms of how they design their trials?
It's funny. I was thinking back earlier today, actually, one of the initial consults I received in 2010 as a postdoctoral fellow was from our bone marrow transplant service. And they were beginning to pilot their outpatient and homebound transplants, which of course have incredible benefits to families for patients to not be isolated in the hospital for months at a time. But they sent me the consent form to take a look at because it mentioned family caregivers, and I had already identified myself as the caregiver point person. And a consent form said, in order for a patient to enroll, to be eligible, they must have a caregiver available 24 hours a day, 7 days a week for 1 month. And I looked at that consent form and I thought, how in the world, A, is anyone going to actually be able to fulfill this criteria? But B, if we're asking families to do this, what else are we going to do to support that family caregiver who's going to be available? And so thankfully, because of that consult, I've been able to work with the transplant service. We've certainly thought about psychosocial support. But of course, since that time, very, I guess, happily, I often do get consulted about other clinical trials that enroll family caregivers or where there's a sort of defined role played by family caregivers. And I think even more broadly for anyone conducting clinical research where all cancer care eventually falls on a family in some way, I think it's very important to consider what is the impact on families. Families are making incredible sacrifices for their loved ones to come for stem cell transplant, to come for CAR T therapy, to come for organ transplant, to come for chemotherapy and radiotherapy, for anything. And I think that we need to probably keep families top of mind when prescriptions are written for a certain medical intervention. Well, how's that going to impact the family? Do they have the financial capacity to pay to travel to the treatment center once a week from far away? Do they need to stay in a short stay hotel near the hospital? Are they able to put food on the table as a result of paying for cancer care? Let me not get into the financial toxicity of cancer and caregiving here, but I think there's a lot of factors that we all need to keep top of mind when we design clinical trials that are going to be burdensome both to patients and caregivers.
And how do you help people transition, let's say, toward and through grief after loss of the person they had been giving care? I mean, that seems like a big transition. You quoted, 8.3 hours, 13.7 of months of time. I mean, essentially, you're now within minutes, in some cases, transitioned from a job that you've worked at full time to now this emptiness. How do you help people manage that?
I really appreciate the way that you asked that question in terms of the transition, because it is an incredibly profound one. And what you bring up is certainly one of the elephants in the room that we address in the Caregivers Clinic, which is that for many caregivers, there are two losses. There's the death of their loved one, and there's a loss of the caregiving role. Now, not every caregiver is going to acknowledge that loss, because certainly for many of us, there's a sense of relief that comes with the end of one's caregiving role. And even those who feel relieved, there's also probably deep down, a sense of loss around what that caregiving role afforded them in terms of connectedness with the patient, in terms of other aspects of life. And so, one of the most important interventions is just actually to label that, to acknowledge that there's been this dual loss, both of your loved one and of the caregiving role. I think the other piece here to acknowledge is very important, that caregiving can be very traumatic. And I think that more recently, of course, highlighted by the pandemic, but certainly not driven by the pandemic, family caregivers experience extraordinarily high levels of post-traumatic stress symptoms, some meeting criteria for PTSD. I have a trial right now where we are supporting both stem cell transplant survivors as well as their family caregivers who experience PTSD. What we're finding is that more caregivers than patients meet criteria. I digress. So I say this because we carry those traumas into bereavement. And so one of the most important things that we do in supporting family caregivers in grief is to help support them around any of the traumas they've experienced. And for many caregivers, those traumas happen towards end of life. It's traumatic to ride in an ambulance and not know if your loved one's going to be alive by the time you get to the hospital. It's traumatic to witness a death, whether that death happens in the ICU while there's a full code, or if it happens peacefully, in a manner that was in accord with patients' wishes, but nonetheless is a death. These deaths are traumatic, and it's traumatic to witness delirium that can often happen at that time, and seizures. And so it's important to give space to process the traumas. And I say that because none of us can healthfully grieve if we're traumatized. That trauma needs to be addressed in order for us to access our grief. And then, of course, I always say that grief is very personal and very unique. There's no one way to grieve, and there's no one timeline. Certainly, there's been in the news and the media some controversy over the labels we use to describe what's been called prolonged grief disorder. But basically, the idea is that everyone grieves differently. And that what's most important is that if grief symptoms are impairing and preventing one in moving forward with their life, it's important to get support. But I find myself, quite frankly, just doing a lot of normalizing of grief and helping caregivers to understand that this is a normal part of their caregiving journey.
So, are there any other things that you'd like to highlight for our listeners and to educate people like myself?
So you all have incredible opportunities. I'm not on the front lines. My clinical care occurs from, well, it's all over telehealth now, but I was never inpatient and I never was housed near the medical oncology suites. You all are on the front lines. You get to interface with families likely on a daily basis. And so I look at you all as the front line. And what I mean by that is that families come to you long before they could ever come to me. And so my ask of you is to take note of the family caregiver who's in the appointment with you. Take a moment to ask them how they are doing and if there's anything that you or your team can do to help them. And even if you have zero bandwidth to help them, at least go in knowing, is there a referral in your institution that you can give to that caregiver? Oftentimes it's to the Department of Social Work or a social worker who's assigned to your service. I think it's very important to ask that caregiver how they're doing and is there any concern they have today that you can address. The reason why this is so important is that too often family caregivers feel invisible. They feel unseen, despite the fact that they are performing such incredible tasks as a result of caregiving, and they're such an important part of the care team. And so you're taking time to acknowledge their presence and to ask them how they're doing is itself an incredibly powerful intervention.
Well, we certainly appreciate all the time that you've given us and all the information and insight that you've shared. It's really powerful and moving to see how far the program has come and how much recognition there's been for a really underappreciated and under-recognized situation. And we're very honored to have you speak with us today.
Thank you so much for having me. Always wonderful to get to talk about caregiving.
Thank you so much for your time. Really appreciate it.
This concludes our interview with Dr. Allison Applebaum. I hope you enjoyed learning about Dr. Applebaum's impressive work. If you're interested, you can find a link to her book, Stand By Me, A Guide to Navigating Modern, Meaningful Caregiving, in the show notes. Thank you for listening, and we hope you enjoyed this episode. Please rate, review, subscribe to the podcast, and check out the journal website for further articles on this topic and more.